Hello, hello. Welcome to our late lunchtime in California live. And I'm going to see here, actually invite our guest today, who is the CRPS PT. I think I might have not gotten her whole name on here. The most amazing Brittany Kim, also known as the CRPS PT. Also going to join for our first live with her today, and we're going to talk about graded motor imagery and talk specifically. Yay!
Hello.
It worked. It seems like a miracle every time this works.
I
So
know.
I was just saying this is like our first live with the CRPS PT, and that we were going to talk about graded motor imagery.
Yeah.
And I told Brittany, by the way, so you should follow Brittany, the CRPS PT right now, because she's been sharing great tidbits on CRPS. And I've just learned so much from Brittany. So very lucky that we get to do this, because I told Brittany, I said, we have been sharing some things like mirror therapy and other things that can be helpful in CRPS, in dystonia, in functional neurologic disorders. And I got a lot of questions from people. And I was like, this is going to be a multi-part series. Otherwise, we'll be here for 2 hours to answer all the questions. But graded motor imagery as some of the like bread and butter in treatments of multiple disorders. And one of the questions that has been coming up, and we've been talking about here clinically, I say here because I'm in West LA today, but what about using the principles of graded motor imagery to help somebody who is experiencing a lot of sensitivity sensory wise, especially to touch, which is so common in CRPS, to actually expose their system and reintegrate to sensory, not just motor input. So that's kind of the question that came up. We've been talking about it clinically, and we all want to know from the expert, and that's you.
Yeah, so I mean, I think a lot of us feel like mirror therapy, you primarily just do movements inside the mirror, and then the goal being either some people will feel like, oh, I'm hoping that this will reduce someone's pain symptoms, which may not always be the case. Some people are doing it to enhance motor function. So mirror therapy, there's a lot of research with mirror therapy and stroke rehabilitation too. There's so many different populations is what mirror therapy is used for. And I think another application that I know gets used, but maybe not as commonly used, is for sensory training and helping people, I guess, prime their brain to be able to accept sensory stimuli. And if you think about kind of and you can comment on this too, Julia, because I think you just did like a live on like the visual inputs. Is this familiar? Like, yeah. So, but basically, I think a lot of people try to summarize mirror therapy into it just activates the motor cortex, but it's more than that. It's so much more than that. Maybe even centers for like self-agency, like areas for attention, the somatosensory cortex. There's so many different areas of the brain that are lighting up with mirror therapy. And so with that said, neurologically, it should work, right? Like hypothetically speaking. So clinically, we do see, and I know I've seen, and I've used this a lot, that doing sensory discrimination type training or sensory desensitization type training in the mirror can be a really great way to help someone's brain feel like that's possible, that's safe. And then that's a nice kind of starting point and a stepping stone into moving into actual touch. And just to kind of share an example, I was working with someone with CRPS, and they were experiencing allodynia, or an increased pain sensation with, in particular, touch for this individual. So touch shouldn't feel like pain. Touch should just feel like touch. So we were using the mirror. On the unaffected side, I was using different textures that she would consider noxious. And she was looking into the mirror. Her unaffected side was not being touched at all. And that actually made a huge impact in her allodynia. We didn't even end up doing sensory training because the mirror seemed to just help her all on its own. We didn't even touch the other foot. I was really surprised. I thought it was going to have to be a progression series, but some people's brains are pretty amazing and can just take that information and use that to help normalize their experience with sensation. So,
Yeah, I remember. That's why I wanted to ask you this
yeah,
question, because I remember when that happened with that other patient, and I was like, I've never tried that. And I didn't, I hadn't imagined it would be so effective. Now, it's not always like that, right?
no,
It's not always like, oh, boom, wow, right? Like, so I don't want
yeah,
to put that expectation
no,
out there that, oh, I tried that and it didn't work. But I do think, and we were even talking about this in our like integrated team last night. Sometimes people try things and they don't work. But you know what? They might work at another time point, right? They might work when a person's nervous system is in a different state or different level, right? And so I do tell people, like, you don't need to beat a dead horse with the mirror. If it
no,
didn't work, you don't need to just keep trying it until it works. Like, sometimes you have to go out of order. And I learned this from you, Brittany. Like, it doesn't always happen in order, like graded motor imagery. And sometimes you have to go and try sensation
yeah,
instead. And so, especially with a person with high levels of allodynia, um, and maybe like somebody even put a question here. So you touch the unaffected
yeah,
side. So maybe you can even walk
oh, yeah,
through, like, how did you actually set that up? Because this was in a person's foot,
yeah.
right? Yeah.
So this person had CRPS of one of their feet. What I did is I put the mirror between their legs. The reflection side of the mirror was facing their unaffected side. So basically, when they look in the mirror, they're actually seeing the unaffected side, but the illusion that's created is it almost looks like you're looking at your affected side. So that's the setup. And then the treatment that I applied was we did discrimination training. We did really strange noxious stimuli on the unaffected side. And I just had her essentially just keep looking. Sometimes I'll even ask people to like copy paste. So imagine that what you're feeling on the unaffected side is happening to the affected side. That could be kind of like a progression almost, is just not just looking, but actively trying to imagine that sensation on that side. And then you could, I guess, like, with other types of mirror therapy interventions for movement, you could do both sides simultaneously, potentially, as well as a progression. So there's a lot of creative ideas that you can use. And thinking about functional things like wearing shoes, or like wearing socks or pants or gloves, or different things that someone might need to use for their daily life or their job. You could put on that shoe, like the stiletto, on the unaffected side in the mirror, and just even imagining what that shoe feels like and then applying it to the other side.
I love that,
Mm-hmm,
bringing it in. And that's what this person is saying. That's what we did, but we haven't tried textures
mm-hmm,
yet. Yeah. And so, I mean, typically, right. And I think even in the video that we shared last week in mirror therapy, this was for a person with dystonia. We had them doing movements
mm-hmm,
that were difficult for them on the affected side. We had it on the unaffected side and watching the mirror,
mm-hmm,
and then progressed to actually doing both at once, where when they had control of it.
mm-hmm,
And I think that's like kind of the traditional thought of
mm-hmm.
mirror therapy, right? Is doing the movement part. And would you say in this person, what led you to try the sensory component?
Yeah, I mean, that was one of her goals. There was allodynia, and that was her goal. So I feel like um, it's the easiest thing to do is just focus on that person's goals. It sounds so simple, but really it is just like they want to wear something, or they are just saying anything that touches my foot is a problem, or something like that. So, okay, then I knew that working on touch with her maybe wasn't quite an option. And so I wanted to take a step away from physically touching her, but I did want to start that process of neuroplasticity and helping the brain kind of connect with the foot, prime the brain for touch. And also, I mean, and I verbalize this too. It's just like, I'm not touching your foot, right? Like it's safe. Like we just kind of keep repeating that. It's like, I'm not doing anything to that foot. And you have to remember that too. And that it's like, so if they do have an increase in symptoms, we know it's the brain. So we just like take a pause and then maybe try again or change what we're doing. But I think it's a nice kind of regression from like, you're like, I want to do sensory training, but I can't touch that foot or I can't touch that limb. Well, don't touch it. Like do something to the brain though. And then maybe see if you can work into the sensory training you're wanting to do.
Yeah. That is great. And I think we get that question like, I can't touch that limb, so I can't do anything. Right? Like it can feel so scary and like a barrier because it's so incredibly painful. I mean, you've talked about this before. CRPS is like the highest level burning pain. I think your logo is even a fire, is it not? It's like fire. It is fire, and it can be hard to know where to start, or and this I think is a really like it's an option. That's not the only thing you could do, but I think it's a really nice option to get started with things. And then I know because I remember talking to you after this case, it was like also can be extremely effective because it's so targeted at the brain mechanism, right? Yeah. And I'm curious just from I've been also just talking a lot about the sensory system and like the homunculus and all of those things. What do you imagine is happening? I know there's some research looking at what happens in the mirror therapy and happening brain wise, but what are we really affecting when we're doing that?
Specifically with sensation or like mirror therapy in general? Yeah, sensation. Yeah. This is me hypothesizing. So I feel like
I don't think they've researched this yet.
Yeah, I wish I had fMRI goggles, not just X-ray, but fMRI goggles. We could see what's happening inside the brain. My hypothesis would be several different things. I mean, because most of the people that I'm using this with have a pain problem. So it's allodynia. And I think like thinking about graded exposure as kind of, and again, like coming from the world of psychology, graded exposure is used for helping people with phobias. And so thinking about how when we're in a lot of pain, we develop a fear of, and then insert whatever it is. So it's like a fear of movement, a fear of touch, a fear of those kinds of things. And at least in my experience, I feel like it's really obvious that this shouldn't be a problem for both of us, like me and the person I'm working with. I'm not touching the foot, like we're not doing anything physically to harm it. And I think the beauty of that is it becomes an education moment of, see, this is your brain and we need to retrain it. So it's like that helps with that. But also I think it gives the opportunity to de-threaten the idea of touch. So there's kind of like that fear avoidance piece, but then neurologically speaking, I really think that during that process, people are just getting that really strong visual input. Vision is just, it's a feedback mechanism. So, and I think for people, if you're kind of identifying, oh, they have a really strong visual feedback mechanism, mirror therapy is, well, it could be either really great or it could be a little provocative or, just because of that strong input. But we rely on vision and somatosensation to help basically calculate what is happening. Is this a threat? And that's kind of the whole pain response piece. So I think neurologically speaking, we're just kind of tapping into those feedback centers to see like, oh, this is safe. And then also kind of lighting up those parts of the brain to better organize together, because it's a more complex system than just like S1's lighting up. It's like there's so many other pieces and parts together. So I think that's what's really nice about mirror therapy, is that it's all the things that we want to do.
Yeah. No, that's so great. I'm kind of like me and making sure so many people joining us, which is so cool. I was just looking to make sure I didn't miss any other questions. You can certainly put them in the comments if you have questions for us, but for Brittany and all of this great expertise. I feel like we'll keep doing a series based on the questions that I've gotten for sure. But is there anything else, Brittany, that you want to add?
I think if you're a clinician, it's worth just kind of seeing how it goes and trying it with people. And like Julie said, I think there is a lot of experimentation that happens in this process of, is the mirror effective? How is it effective? When do I use it? And those kinds of things. And like Annie's mentioning here that Annie's been using it with acute adhesive capsulitis. Actually, my favorite opportunity to use it, after I went to Adrienne Lau's talk on the frozen shoulder has a brain, I did it with several people with frozen shoulder, and I've never seen so much range gains in just one session of mirror therapy. It was like we didn't even move the affected side, and suddenly it was like 15 to 20 degrees flexion, and I was just not expecting that. So yeah, the mirror is really cool. It's worth playing with. Doesn't have to be for CRPS. It could be for other types of diagnoses. You just got to think about the mechanism, and if that mechanism is the issue that your patient is experiencing. Mm-hmm.
Yeah, that's great. That was one of my favorite of all time talks, was the frozen shoulder has a brain. And literally nobody should be doing frozen shoulder treatment without sensory training. Mirror therapy, super effective in very few visits, right? And somebody is asking, what is the best treatment aside from SCS for CRPS?
I'm gonna guess that is spinal cord stimulation as a treatment intervention, which is a medical intervention where the pain management specialist, sorry, I think I have a lullaby playing in the background.
So I didn't hear it, Brittany.
Okay, it was like his favorite playlist is playing in the background.
So used to it.
I know. Okay, so I think if this is what you're referring to, spinal cord stimulation. So basically someone is implanting electrodes and leads into the spinal cord as a form of pain management. And that's something that, at least in my experience, I've seen is not a first line treatment. It's usually something that gets visited after several different types of medical interventions. And what's the best? Honestly, that's a huge, it depends on the person. I've seen things like, or I've, people have had blocks and that kick CRPS to the curb. I've seen people where blocks are somewhat helpful and they need physical therapy and different kinds of services. It's really a huge, it depends on the individual. I know at Re+active, and I have a very strong belief in this, is integrated care, I think, is one of the best ways for people with CRPS to make really great gains in their functional abilities and help with some of their pain management, because with CRPS, the brain is rewired, and it's not just the parts of the brain that feel and move, it's the parts of the brain that also have to do with cognition and emotion and all these different things. And we need to kind of work together collaboratively with other healthcare professionals to make a big difference. So yeah, I would say it depends. I hate to say that, but there's not a one answer, unfortunately. I wish it was like a magic wand or a magic pill, and it was just like over, because CRPS is really hard. Mm-hmm.
Yeah. I lost my headphones here, Brittany. Can you still?
Yeah, I can hear you.
Yeah.
Mm-hmm.
Yeah. And we got a couple other things. What if color and not just texture is the issue?
And I guess that being that someone's having color changes, I would imagine like a red sock versus a blue sock is not the problem. I think it's more like the limb itself is changing. Okay. Color changes are also really interesting. I'm going to say I don't know if like the mirror would make an impact in that. And I'll just share kind of, this is my personal and professional opinion on the color changes is, while I know they can seem really concerning, more often than not, most of the people I work with are more concerned about their pain. And so that's something that I feel like is a little bit more of a priority for managing. The color changes can actually change over time. And that could be within a person, or it's just like as people make improvements, sometimes those color changes start to diminish. So yeah, I think that's another, like each person with CRPS is so unique. They're just so unique, with even the color that they come in with. And it's like day 1 versus day 20, like who knows what that color will look like. But I think getting back to life is really like so much more important in my mind, than if the color is completely changed.
Now, of course,
Yeah.
this person is actually saying it is the color of the
Oh,
surface that.
okay. Well, for those who were interested in the limb, I've answered that question. What if color and not just texture? That makes me think of like maybe there's like a visual sensitivity, or I think I would need a little more information about that. I feel like, I mean, with the concept of the mirror, yeah, you could apply the same concept, I guess, if it's related. I think I would really need to understand like the context of that situation
Yeah.
to put it together. But it sounds like that's some sort of visual sensitivity, or there's a strong association or something,
Yeah.
with
I was kind of thinking of this, like whenever I think of the
yeah.
sensory systems, they're all integrating, right?
Mm-hmm.
So visual, somatosensory, vestibular. And so like even the surface the person is sitting on or standing on, and
Mm-hmm, mm-hmm.
so something is happening here with that visual input that is making a difference. And maybe in a straightforward neuro world that doesn't totally
Yeah.
make sense, but in the world that the brain is actually not like separated but integrated, it almost like, yeah, for that person there is something there. Like we think a lot about synesthesia, where people
Mm-hmm.
actually feel in colors or feel in musical notes, and it's actually kind of like something, you know, is differently wired there. I would, it sounds like that. And I think that's really interesting, and something, you know, yeah, visual sensitivity. You hit the nail on the head, Brittany. And so I think we have to, this is where I love to zoom
Mm-hmm.
out with OT and PT and psychology to go, oh, we need to integrate all of these systems. We can't just look at this like sensory, biomechanical, motor control of the limb. Like that's integrated with the other systems. Which is, we're biased,
Yeah.
of course, to look at integrated care. And I just wanted to note, somebody also said that the blocks made flares worse. That's definitely, you see all responses to all of the things,
Yeah.
right?
Yeah.
I think
Yeah.
that's totally the case.
Mm-hmm.
And then somebody else said, I only change color when I have flares. Is that a common problem?
So I have seen that, and I've also seen some people just have, I don't know how to describe it other than a colorful foot. Like it just decides, like as if it had its own wardrobe. It's going to be red today, a little blue tomorrow, and then like 5 minutes from now, it's not anything at all. And so yeah, like I said before, I really have seen that a lot of people with CRPS are just very unique in presentation. But I have seen where sometimes when people get more flared, then those color changes kind of start to happen as well. So you're not alone. And I just also want to make sure that other people who have CRPS know that it's not unusual for their foot to not do that, or to just do its own thing. Yeah, sometimes it just has a mind of its own, it seems.
Yeah.
Yeah.
Color, I think the other thing, sometimes when you see the color change, either as the clinician or
Mm-hmm.
it can be like, oh, what happened, right? Because you
Yeah.
equate like blue to like a bruise, or, you know, you have these associations, and it's not always the case that there's like actually something occurred, like an injury, right?
Yeah, it can just be a representation of like a nervous system response. And another really great example of that, where that it's like, it shouldn't be like, we're not damaging anything, is some people will have that color change when their foot is in a different position. So sometimes when it's down, that's when I've seen people will more likely have the color change. And part of it's just the physiology of what's happening with CRPS is the autonomic nervous system is just a little funky, and that's responsible for changing the, like, whether your blood, this is the blood vessel, by the way, so like your blood vessels are like dilating or constricting, and when it's a little funky and not doing what we would normally expect, then sometimes that's where you can see the color changes. So it's just a function of a funky physiology in that moment, but things can change for the better. Some people have improvement in that as well when they get more active and things like that. So yeah, I feel like that's what makes it hard with CRPS, is it feels really random sometimes, or unpredictable, or there's these like weird symptoms, they're happening now but not later. And I would just say that that is really typical of CRPS. And it's something that I just appreciate in the individual, whoever has it, and how they present. It's very individual. Mm-hmm.
Yeah, that's great. Plug for individualized
Yeah.
care right there. And a plug for autonomic nervous system training.
Mm-hmm.
Too, I think if you have autonomic dysregulation and it's causing some of these changes, whether that's like the color or even
Temperature,
the texture, like all of those pieces, then you want to incorporate the autonomic nervous system into treatment for sure. Well, we're turning this into CRPS.
Yeah, I know.
Class here,
I know.
Which happens to me all of the time. I intend to hop on for 15 minutes, and an hour later, I've got great questions, and I can't stop talking. The folks that join us for our lives, you're just amazing. And so I just want to say thank you to people for sending questions, and for just your curiosity and interest. I send out, today's the day, actually, Friday. If you're a clinician, I'll send out videos from the week. I've referred to a few articles this week. I'll send out links to that. You can sign up for our newsletter at reactiveeducation.com. And if you are a patient, a person with a neurologic disorder, or a family member, we send out a newsletter every Monday, videos, links to resources and articles, and you can sign up at reactivept.com for that. So keep the questions coming. We love this community a lot. And Brittany, I'm so happy that you joined us. I can't wait to do this again and to talk more of these intricacies of the brain. Very interesting. All right. Well, thank you, everyone. Thank you again, Brittany. Bye. And have a good day.